Welcome to the Thinking Practitioner Podcast.
A podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Tel Luca.
Welcome to the Thinking Practitioner. Welcome to the Thinking Practitioner, and our podcast is supported by Handspring Publishing. Their catalog has emerged as one of the leading collectors of professional-level books written especially for body workers, movement teachers, and all professionals who use movement or touch to help patients achieve wellness. Handspring has recently joined with Jessica Kingsley Publishers' Integrative Health Singing Dragon imprint. So head on over to their website at handspringpublishing.com to check out their list of titles, and be sure to use the code TTP at checkout for a discount. And thank you again, Handspring. We're also sponsored this week by the Academy of Clinical Massage, where our mission is to help you become a better practitioner working with pain and injury conditions. And 2023 is bringing a complete overhaul to our comprehensive orthopedic massage program, and we're excited to announce some new opportunities to make our training even more accessible. Our full professional program package now includes numerous perks in addition to the coursework, and we have just introduced a new payment plan for that program to make it fit your time and budget even better. So check out more details of that program over at academyofclinicalmassage.com. So welcome everyone to Thinking Practitioner. I'm absolutely delighted to have my friend Walt Fritz in with me today. Good day, Walt. How are you?
I am doing well, Whitney, and thanks so much for having me here. Really appreciate it.
Great. So for our listeners who might not have been introduced to you yet, can you tell me a little bit about your background, experience, what you're doing, what you've been doing, and what you're up to right now?
Absolutely. I'm a physical therapist based out of upstate New York, and been a physical therapist for a long time, 1985 graduate of the University of Buffalo. So since then, been doing a lot of different things: pediatrics, home care, general hospital, developmental disabilities. And throughout that path, I've but got into manual therapy because, PTs, here we touch, we do manual therapy, but possibly in different ways or from different perspectives than the massage therapist. And I was introduced to manual therapy via myofascial release, cranial psychotherapy, zero balancing, and that's what got me started, which I kind of followed the myofascial release route for a number of years. And then for a lot of reasons, ended up leaving that model and kind of looking for a new sense of self and a new community. And that's what's over the last 15 years kind of led me on my own path of where I'm at right now, which is teaching and practicing manual therapy from a very non-traditional, non-conformist type perspective of shared decision making. And I hope we have an opportunity to talk about that if you're interested.
Absolutely, yes.
Yeah, because it's really been the focus of my work, my research, my writing, and my practice for the past really 6, 7, 8 years is the shared decision-making model. And I continue to teach continuing ed seminars. What started more as massage therapy, PT-directed classes has taken an interesting left-hand turn. And I'm now primarily teach speech pathologists and other people working in voice, swallowing, breathing, oral motor disorders. But that includes a fair amount of massage therapists who come to my classes for various reasons. So that's my nutshell.
All right. Well, that's got a rich group of things that we want to dive into. So I want to kind of go all the way back to the beginning here, and we'll sort of wheel our way through some of those things there. Tell me a little bit about your beginning entry into manual therapy. I know, the whole issue of manual therapy is viewed, at least from my perception, a bit differently within physical therapy from what a lot of our listeners do who do this on a regular basis. What was it that kind of got your interest piqued about doing more hands-on manual therapy work? Because I know a lot of people in a lot of my colleagues that I've talked about who are in the physical therapy world feel like they don't get time to be able to do that kind of thing because of the pressures of some of the economic models with the insurance reimbursement, things like that. So what got you going down that path?
Well, I mean, we had a fair amount of manual therapy education in college. It was a bachelor's degree program back then, so a lot less time for each sort of module, so to speak, versus the doctoral program of the present day. But, that included, we learned massage. We had 2 very compressed and rather lame weeks of massage training, which technically legally licensed us to massage, having helped the patient who actually relied on me for that kind of care. But Manual therapy is a broad term. To physical therapists, manual therapy can mean joint manipulation, joint mobilization, and very frequently in the literature, manual therapy is codified for joint manipulation, spinal manipulation. But it really is the broader term that I view it as any kind of touch-based interventions.
Mm-hmm.
I know that in the late 80s, early 90s, when I was, kind of a new practitioner working in a more generalist model, I was doing early intervention at the time, birth to 5. We hired a physical therapist at the clinic I was working at, who had done some training in myofascial release craniosacral therapy back in the 80s. And, he did a healthy amount of real and metaphoric arm twisting to me to get me to take a myofascial release and a craniosacral therapy class. I was reluctant because at the time, my national organization, the American Physical Therapy Association, was really down on down on myofascial release especially, and was kind of doing a concerted effort of trying to discredit it. And I read that every month, and I really had no interest in it. But the arm twisting worked. I took a class and I got hooked. It was, without sounding like I'm sexualizing it, it was very seductive.
Mm-hmm.
It was very intriguing, sort of that what happens when you get in a room with a speaker who's good at speaking, who's good at selling, who's good at convincing. And I don't mean that in a negative way at all, but the story becomes very compelling. And then combine the story with the actions, the quote unquote outcomes. I went headfirst into that rabbit hole, and I went hard. Went hard into the myofascial release rabbit hole, especially, so much so that I then worked for that particular person for 10 years as a teaching assistant. And I learned a lot. I learned a lot of really good hands-on skills. I learned a lot of really good interaction or relationship pieces with not only my patients, but also all the students that I was responsible for helping. It wasn't until later that I really kind of realized that in order to see the forest for the trees, I had to leave that model and try and get some good critical thinking skills embedded in my brain beyond just that secret story of the fascia and everything else. So,
mm-hmm.
And I'm a PT. This is what I do. I have a very small practice here in upstate New York, where I do accept some insurances. And you talked about the economics issue with traditional physical therapy therapists having trouble applying manual therapy. It is more time intensive. It doesn't fit well with that model where you're in a big clinic with multiple people, both support staff and clinical staff, with a huge budget, et cetera. And, reimbursement dollars aren't always the greatest. So as a result, the PT is seeing multiple people at once, but I continue to see one person at a time. I think probably just like you, Whitney, and just like a lot of your listeners. And if you walked in my office, it would look a lot more like a massage office than it would a physical therapy office. But, it's just some of the things we do.
Mm-hmm. There's been a lot of buzz and talk within our profession in the massage therapy world about improving our training standards and credentials. And we've talked on this podcast with a couple different guests about that. I'm curious to hear what your thoughts are about the move to the DPT model in the physical therapy profession, how that's impacted individual practitioners or the access to care from patients.
Yeah. I kind of look at it in two different ways, and both of them really are oppositional. I think as a professional accomplishment, as a notoriety for the profession, as well as really, having some really high standards, I think the DPT has been really good. I think it's a bit overkill. I think they could have stopped at the master's and got enough education and information and clinical experience to students in back then, but that, they moved right along to the doctorate profession. I know that it is, in many cases, it's priced the student, a lot of students, potential students, out of the market, because it's, any doctoral program is really expensive, especially when you then look at the commensurate pay that you're getting for a doctoral level position and job that doesn't quite keep pace with some of the other doctor professions. Yeah. I don't know. I'm a moderator of a lot of groups on Facebook, and one of them is a massive physical therapy group that it seems like every week there's somebody really questioning their choice as a physical therapist. And a lot of it comes down to economics and the crushing caseload that a lot of physical therapists are expected to to maintain. And you know what? I've been able to stay away from that, having my own practice and kind of doing things my own way. And I'll probably retire doing this. So, it's not a great concern of mine, but I know it is for the profession.
Yeah, I've probably read a lot of those very same threads that you were talking about, because that's what kind of got me wondering about this, was seeing a lot of discussion in a number of those different physical therapy groups about these very issues, and just wondering like, wow, are we trying to sort of stare down that rabbit hole and go down this same pathway of continuing to, there's, some discussion about, somebody called it credential inflation, I think was the term that they were using, about just constantly feeling like we need to up the level of credentials and keep pushing and keep pushing. And, so many of the physical therapists in practice were doing a lot of what chiropractors and physicians were doing, and that time in terms of the level of involvement with the assessment and treatment process, and kind of thinking like, well, we should be doctors also. And I think that may have been part of what drove that model to the DPT.
I do think that the evidence-based model really didn't come into play until the 90s. I graduated from PT school well before evidence-based practice was the required norm, the expected norm in the physical therapy profession. There's a lot of detractors of evidence-based practice, and I understand some of those concerns, but I think a lot of the concerns stem from one's own beliefs and experience not aligning well with current-based evidence, and the expectation of an evidence-based practitioner. And I do see from, clinicians coming out with that DPT, or even, and certainly the masters of physical therapy, and maybe to a lesser extent, older people like me, a really a solid understanding of what it takes to make an evidence-based model. Is, it's lacking in people like me, but that's really at the forefront. And, from other professions, I see it really easy to sell people on things that are sort of counter evidence-based, and it almost develops a cult-like following to not be evidence-based. And but that's not just in our shared professions. Look at the world today, and without even getting political or social. It's almost like, we're running in parallel universes, and there's just thousands of these parallel universes. And, if you spend any time on social media, you're reading all these things in a niche group of, it's all about the fascia, it's all about the trigger point, it's all about the neurokinetics, it's all about this and this and this. And it's like, man, oh man, aren't we working with a human being and not a collection or an isolated tissue or pathology or view of how things work? And it's a frustration for me. I've been very frustrated. I've been very vocal. I've been, probably not the most popular person in some groups, because I'm not afraid to say that the emperor's got no clothes, but they're not always popular things to hear and say. So
I want to follow that thread a little bit farther and call back. I'm pretty sure, I think this is something that you said to me. Somebody said this to me one time, and I think it was you when we were having that conversation we were just talking about in the green room before our thing about when the last time we were together in Winnipeg, I think it was, having lunch at a conference. And I believe it was you that said this to me. If you took 3 or 4 different practitioners and put them in a room and videotaped what they were doing and took the sound off, and then asked what was being done in those treatment sessions, what techniques were they using, what modalities were they using, it would be really hard for the observer alone to say what was being done just based on what they're seeing performed. That so much of this has to do with the narratives that we create around those types of techniques. I don't remember if that was actually, was it you? Do you remember us? Yeah. I thought that was such a brilliant analogy. I've stolen that and used it many times in talking about this. But this issue about these sort of particular modalities or silos that we create seems to produce a lot of obstacles in that way. And I think that was a great way to kind of break some of those barriers down.
I see it. I see it in the massage world. I see it in the PT world. I see it now that I'm in, these other worlds, speech pathology and malfunctional, orofacial malfunctional, that, we're all so blinded by the narrative of our story. And I really, I guess I've modified that story since we met in 2015 a bit, and maybe a little bit, smoother to tell that story, but it's still true. You know, you step far enough back and basically we're touching another person.
Hmm.
But yet as you get closer, right, we get closer to each one, then the story gets magnified of what we think we're touching, what we think is wrong with the person, what we think that our touch is capable of influencing. And you know, you and I have been there, and hopefully you and I aren't in the driver's seat of teaching people this, but it gets really tough to say no to a really good story when you're presented not only with the work, you know, and the outcomes, and you feel better from it, but then somebody gives you what is said to be evidence and science to support that. You know, when I was taking this work back in the early 90s, I didn't have enough critical thinking skills or, you know, research-based chops to really adequately question evidence as it was presented to me. And I basically just accepted it because the work was so helpful.
Hmm.
And
Yeah.
you know, it's a classic inroad to post hoc fallacy. It's like people tell you something, the stuff works, and you believe their story when those two things might not have anything to do with each other. And
Yeah.
I think it's really unfortunate.
Yeah.
You know, I do think that we are in minorities there, and it's tough when you start going out there. You know this because you're out there on the road, and
Mhm.
you start talking to people who have a firm set of beliefs, and it's not just manual therapy beliefs, it's social, it's political, it's religious belief. You know, we don't like to change our mind,
Yeah. Right.
because why should I, you
Yeah.
know?
Do you think this is something that I pondered in talking about this with a lot of people around this whole issue of these narrative models around our, theoretical ideas, what we think we're doing, a lot of those people, does that matter? I mean, does it influence the treatment at all? You know, for somebody who like is really bought into this particular model and they get really good results. And what you often hear is
Mm,
like, well, I don't care because I get great results and it works for me. So
yeah.
does it matter then that we're really trying to make those narratives more accurate? And I mean, I'm curious to hear your take on that.
Yeah. So you can almost step back from that and ask almost at a philosophical level, is it a lie if you don't know it's a lie? Is it is it a mistruth if you believe it to be true? Um, I don't know. That's a real moral and ethical type of quandary for each person. I look back at my MFR days, and I was telling what I thought were truths.
Hmm.
And you know, my great undoing was the Soma Simple debate of 2005, where you know I kind of went head to head with some really smart people who knew a different story than I did. And that made me, it was sort of like a 5-year whirlwind of, you know, me having to really look at everything that I believed and
Yeah.
trying to make amends for that. Um, I don't know. That's a hard one. I, I, I believe that the more I learn, the less of which I'm certain,
Hmm.
which is really a difficult thing
Yeah.
because I sounded really smart 15 years ago when I was an MFR expert. And now I think I know a lot more, but I may not sound quite as knowledgeable because I know there's a lot of uncertainty in everything that you and I do and teach.
Hmm.
And I actually enjoy that uncertainty, and I'm really comfortable sitting in uncertainty. But I do understand that number one, a lot of people are not comfortable there, and number two, we get so invested in our leader, in our mentor, in our teacher, in our guru, whatever that is, that it's painful to actually even have to open that door and say, was this person not wrong, but not totally correct?
Yeah.
So I can understand and empathize with clinicians' difficulty. And you know, you're on a bunch of the same groups as I am on social media, and there's a lot of constant, you know, hand wringing. It's like, how do I come to grips with all of this? And
Yeah.
everyone's sort of charged their own path.
Yeah. One of the metaphors that I've sort of gone back to over and over again about dealing with that myself, because I certainly have had those same quandaries and instances in which my former world model of how I thought everything worked in the manual therapy world got really cracked and fractured and, led me to question a lot of the things that I was doing. But a metaphor that seems to give me some sense of solace or comfort around that is a comparison with the world of physics. And I've always been kind of fascinated with that. And you look at something like classical mechanics, which is, Newtonian physics about, how forces act on things at a certain level, and there's rules and guidelines that are helpful to give us an understanding, to give us a framework to be able to understand some of those things. But when you get down to the subatomic level, those things don't work anymore.
Mhm.
And it's not that we should throw them out. It's not that we should completely say this is irrelevant because the stuff at the subatomic level has told us like none of this really works. That's not really how it works. It's like at a certain framework and at a certain level, that's a pretty good model for describing the sense of reality of what we encounter, but also recognizing that at another level, there's a place at which it kind of breaks down and you need to shift your frame of reference and be able to look through a different lens at things.
Yeah.
And I do think that's challenging, but I also think it's helpful to give us some models of ways to look at it.
Yeah. Yeah. I know it was interesting because when I started teaching, well, I taught for John Barnes and myofascial release God for a while as a TA for him, and then once I left that model, I moved off on my own. And it was interesting because in that, when I was still teaching myofascial release back then, I had evidence, right, or I had the evidence that other people thought was important, and basically I was quoting or writing, if a study was complementary to myofascial release, then I used it. I cherry picked that. And if it wasn't, then it didn't go on my reference list because it wasn't proving what I wanted to prove. And that worked for a while. And I don't know what I don't want to say it worked because it was PTs and massage therapists. It worked because that's the model I presented from. I think that's probably the most fair. But then in 2013, when I started getting introduced and got invited into the speech pathology community to start teaching to them manual therapy, there's a very different structure on how they look at work, what kind of evidence they need in order to even consider. Then that was part of this long process of saying, I need to be able to better support not only what I do, but how I explain it. And then that big wall between outcome-based studies, which is we need them, right? We need outcome-based studies. When we do, I'm going to use myofascial release. When we do myofascial release, right, a person got better. But what is that study saying? And this took a long time. What is that study proving? Is it proving that fascia was restricted? Or is it proving that when we do things that we call myofascial release, that's helpful? So kind of unpacking that. And, to me, the past 5 years, really getting to the core of some of the explanations of mechanism of actions of our touch, both from that tissue-based quality, the neurocentric qualities, the behavior qualities, the autonomic, everything that comes into play there. It's really frustrating. It's confusing. It's deep. And I think it's just like magnificent work because there's so many possibilities for why a person is helped when we touch them. But yet each of these little camps breaks it up into this small little thing instead of saying,
Right.
You know what, we're touching a human. Anything else is just, it's speculation.
Yeah. So with that being said, this is a question I hear a lot, like from people as they start to grapple with these difficult models and difficult questions. So how much does that technique matter in comparison to some of these other things that we say are relevant aspects of that, human interaction and that therapeutic alliance?
Sure. Well, what is a technique? To us, as we're taught it, often the technique is how we place our hand, the direction we move, the amount of force we use, all those things that sort of come as an enmeshment of the modality or model that we learn. But when you really look at what a technique is, there's incredible contextual aspects to it, right? There are, people don't like the word placebo because it seems they mistake what it is and what it isn't. But when someone comes in to see me, air quote expert, that carries context, that carries value in and of itself, especially if it was a referral source from somebody they really trust, right? So they're walking into our room hoping and expecting from us to have the answers. And here we go, we tell them this story of fascia or muscle or, fill in the blank of the thousands of things we talk about. And they sit there and they nod their head like they really understand. And they're just saying, okay, come on, get on with it. Help me. How much is it? How much is the technique of the actual physical thing that we believe we're doing to the tissue? And how much of a technique are those larger aspects, right?
Yeah.
I've been reading a lot lately of, the concept of interoception and how C-tactile afferents feed into interoception via contextually appropriate touch, etc. Interoception, to kind of simplify it for myself, is a person's ability to self-regulate.
Mm-hmm.
When we touch somebody in a certain way, we're turning on a person's, I hate using some of these words because they get a little colloquial, like self-healing mechanism. That can go a lot of different directions. But the human being's ability to self-regulate our own internal environment, there's actually evidence out there that says our contextually appropriate touch can actually foster those centers in the patient by simple transmission through C-tactile afferents. That's not about technique at all. That's almost about affect, right? Versus technique. Touch is complex. There's so much good evidence out there, and it's not just in the manual therapy literature. It's in the behavioral, the psychological literature that's talking about all these overlayments of how touch can impact the human being, not the muscle.
Yeah. Let me ask you this in terms of like when you're working with I'm going to create a hypothetical situation here because I've had this happen numerous times. You're working with somebody who comes in very much attached to a particular narrative about what's going on with them. My fascia is twisted. My, trigger points are on fire, or whatever it is, the story. And that story doesn't really fit with what, let's say, our current understanding is of the evidence, but they're on this story and very attached to this story. How do you work with that? I mean, because I've made some bad mistakes early on by trying to correct those stories and created a really dysfunctional, non-therapeutic relationship problem there that was then ineffective. So, how do you deal with that?
I deal with that by, first of all, never feeling like I have to take their story away from them. All right.
Yeah.
I want to form a therapeutic alliance with this person, and often that means don't do anything to break it, right?
Yeah.
And if I immediately start, just tearing their beliefs apart, and whether it's their internal belief system or someone else from their past and present who's sort of helped them adapt that story, it seldom works out well if I end up demeaning them or demeaning another person. So what I do is I sort of bide my time, and if they turn it into a question to me, that's when I have an opportunity, right?
Mm-hmm.
I'm pretty good at staying quiet anymore, which is an art for me. It took a long time to learn, but you know what? Somebody's story, it's their lived experience, and no matter how much you and I know, we've not lived their life. So don't insert that into that I know this person's life. But should you, Whitney, say to me, after we do our evaluation or whatever it is we're doing, what do you think about those trigger points, Walt? Are they worse you ever felt?
Yeah.
And, I could say, and this is kind of how I model this with my patients as well as when I'm teaching this work. It's like, you know what? A lot of people think that those tight spots are trigger points, or, are really our trigger points or fascia restrictions, or fill in the blank. And then what I like to do is insert an alternative narrative. Now that narrative tends to come from my perspective, and I tend towards more neurocentric explanations. And I said, it could be that trigger point that your doctor told you about, or it could be a sort of a neurologic remnant from a past injury that your nervous system simply hasn't let go of yet.
Mm-hmm.
That's not exactly a perfect science-based explanation there either. It's simply giving them the opportunity to see that there might be more than one way to look at a problem.
Yeah.
There was a study that I wish I had my hands on it. I read it years ago. But it was sort of at the onset of the pain science movement, right? When things were shifting from, tissue-based stories to the pain is a construct of our brain, et cetera. And there's a lot of, talk about something that's just guaranteed to start a fight on Facebook. It's about pain science, right?
Yeah, right.
But what it was a study done for physical therapy for non-specific low back pain, where what they wanted to figure out was, did pain science education make a difference in a patient's beliefs? Okay. Mm-hmm. So what they did, they constructed this study where the physical therapy session was simply an education session. And they did a pre-interview and a post-interview with the patients. And basically, patient came in, they said, okay, patient, what do you think is going on with your body? And invariably, it was something along the lines of tissue damage or muscle weakness, right? Those are kind of two classic things, right? Or their posture, all those other things that we like to blame, right? And then it was, in essence, it was an hour-long education session by the PT, providing them the most up-to-date pain science education, dumbed down a bit for the patient to understand. And then they did the post-interview, and this tremendous majority of people walked out still believing what they believed when they walked in, which is either really, really like bleak, how much does our education matter, or more of an eye-opener for us that, narratives are tough to change. Mine are, yours are, and so are the patients.
To me, that was really, and I read the similar study, and one of the things that struck me about that was, and I've mentioned this a number of times on the podcast, I have a passionate obsession with learning science in addition to, what goes on with our clinical work here, and learning a lot more about, neuroscience and the process of learning, and the idea that we can have somebody walk into our clinic and instruct them on the complexities of the neurological system and these concepts in, a few minutes of an interview discussion process with them, and have them really get it. When it took us, often many of us clinicians, years and years and years of gradually moving towards that by constructing and assimilating knowledge based on, compiled understanding of things. It's a little bit naive to think that we can do that in just that short few minutes,
It is, yeah.
And another thing that, that's kind of about this in terms of the way people look at things, and this kind of gets back to the whole brain science thing. My wife often makes fun of me because I cannot find things that are right in front of me. Like I'll go look for, do you know where my teacup is? And it's sitting on the counter right in front of me. And, I know this is, of course, getting worse with age now too, but the thing that's interesting about that is the part of brain function that's happening there, which is that I've got a picture of what that particular thing looks like and where it should be. And if it's not right where I think it should be, I will actually not see it. Really, my brain will actually not register that it is actually there, even though visually it might go through my eyes. The brain, which assimilates all that visual information, just will not see that. And I think that's a lot of times what we're talking about with the frameworks that people come in with. They have a framework, and you just cannot change that in a session or two. It's not going to happen.
Yeah. In terms of evidence, et cetera, people are often asking me, what's the evidence you use to support your work, right? Which is a valid question, right? Like there's one paper, there's one whatever that totally sums up, an entire process. And I actually just wrote a little post or put it on social media a week or two ago. And, if I really had to evaluate myself and take a look at what I've learned, and especially in the last 5 years with all the writing, et cetera, that I've been doing, I think there's one paper, Whitney, that was really most pivotal in getting me to see the forest for the trees, if you will. And that, believe it or not, it's a 1957 paper by psychologist Carl Rogers. Carl Rogers, and I so love this paper for what it says and what it doesn't say, because Carl Rogers in 1957 wrote this paper and presented it at a psychological conference that basically got him ostracized from the profession. He presented a paper which said, in essence, that it's not the modality that you use, it's not the tool that you apply that creates change in another human being. It's the relationship that you build with them. And I thought, okay, so we can't, you can only transfer so much of that to a manual therapy, physical therapy context, et cetera. But that view is something that needs to be looked at today, where, social media and every other kind of advertising is just loaded with all these camps, all these modalities, all selling the best things since sliced bread. Right. And I think we need a good dose of Carl Rogers saying, what's the common denominator in each and every one of these interventions? And it's the relationship that we build with another human being. And honestly, that's where more of my but learning has been over the last 5 years, is looking almost at those psychological and philosophical aspects of the relationship that I have with a patient and I have with a learner in my classes.
Yeah. Yeah, that's fascinating. Interestingly, Carl Rogers wrote the book that ended up being my very favorite book that I read during my time in college when I was a psychology student. He wrote a book called Freedom to Learn, which was about the learning process. And it was sort of a groundbreaking book for me because I had been up until that time very attached to this model of like, you have to go to school to learn X number of things, and that's where you go get your learning done, and then you leave.
Mm-hmm.
And that book really opened my eyes to understanding that learning is really all about what you want to do, when you want to do it, and how you make it apply to all kinds of things. And, as a 20-year-old college student, you kind of use that book as an excuse for like, well, then it really doesn't matter if I study after the test or before the test, because if I really want to know this stuff and learn it, I can learn it later on. So that was my excuse for not getting good grades on things sometimes.
There you go. Yeah.
Well, listen, I want to change track or shift tracks a little bit here and talk about your shared decision-making model and that sort of clinical reasoning process, because this is another topic very near and dear to my heart. So tell me what you're into and exploring now along those lines.
Well, okay. So can I do a shameless plug here?
Go for it. Yeah. We're all about that here on The Thinking Practitioner.
Perfect. I got a book coming out. The book is called Manual Therapy and Voice and Swallowing, a person-centered approach. It's being published not through Handspring, but through Compton Publishing. And as a result of that book, that really I chose to do it, right? That plus I embarked on a master's program during COVID when nobody had anything to do. And between the master's as well as the book, it essentially allowed me an excuse and a reason to really reframe how I look at my work, how I explain the work, and the underpinnings of my work. And the thing that kept coming up repeatedly is the distinction between the clinician as expert model and the shared decision making model. Diane Jacobs, who you're probably familiar with, and Jason Silvernail, they wrote a paper back in 2011 on the operator versus the interactor model. The operator is, in essence, the clinician as expert model. People come in to see us. They deferred to us just about all the concerns, all decisions to a certain extent. Certainly it's variable, but they need help. They come to us because we're experts, and they'll often defer to us to allow us to make choices for them. And quite frequently, I mean, let's face it, Whitney, that's how you and I were probably trained. I can't speak for you, but I was, that we're expected to know what's wrong with them, and we're expected to know the best intervention. And that biomedical model, that works. I mean, it's been proven for decades now. But there's been a movement over the last couple decades of trying to recalibrate the power in that relationship. And, Diane and Jason talked about it as, instead of being an operator, one person basically running the machine, as two people interacting with each other. And I think there's a lot of similarity between their theory or their proposal there, and a lot of the evidence in shared decision making, both in behavioral as well as the physical sciences. And essentially, the way I sort of bring that to the public is through the statement, I know a lot, I've learned a lot, I've trained a lot, I've experienced a lot, but there are key things missing from my knowledge, and that's essentially knowing your lived experience, knowing your values and expectations, knowing your fears and hopes, etc. So what I try and do is incorporate my version of a shared decision-making model by, in essence, let's just pretend here a moment, we're looking for a problem, right? That my training said to me, oh yeah, there's that fascia restriction. We found it. And then, we tell them about it, and then we'd make suggestions on what we should do with it. But in a very simple form, what I try and do now is I still do that tell-patient model. And when I feel it, or what I think to be it, instead of saying, Walt, you're so brilliant, you found it, what I do is shut my trap and say, what do you feel? Whitney, what are you feeling right now? Right? And without leading them on to say, what do you feel here? Or do you feel your pain? I try and keep these open-ended questioning, right? What do you feel gives the person a chance to answer from a very wide lens, right?
Yeah.
I feel pain. I feel pain. I feel fear that makes me anxious, whatever, giving them the opportunity to answer with an open lens instead of a very closed lens. And then instead of me telling them what should be done, to me, evaluation and treatment are, I use the slow, static, dry engagement that's very typical of myofascial release. I don't call what I do myofascial release anymore because I don't think I'm treating fascia, but I still use that model. So instead of me then doing the things I was taught, where it's taking up direction of ease and they'll take up the slack and all those things, I use that kind of model in a wandering, exploratory style fashion. But by telling my patient that I need their help, I need them to tell me what feels like it might be helpful, what feels like it could be a positive engagement, or conversely, if there's anything that feels threatening or a waste of time. Patients sometimes really balk at a shared decision-making model because I don't, force is too strong of a word, but I highly encourage them to become an active participant in it. Some patients relish that. Other patients really kind of, no, I don't want to do that. They leave, they go look and find somebody who will be the expert and tell them what's wrong with them and what should be done. But to me, shared decision making, well, if you look at the evidence for shared decision making, there's smaller pockets of evidence in the manual therapies like you and I are doing that shared decision making can actually ramp up outcomes. But in the larger medical and healthcare sense, there's ample evidence to say empowering a person in their own healthcare decisions actually improves outcomes, improves patient satisfaction. And Whitney, patient satisfaction is one of the most massive contextual factors that you and I can leverage, right?
Yeah, right.
So in a nutshell, that's sort of the way I go about shared decision making. When I teach a class, I one of the first things I say is that while all of you might have thought you came here to learn some nifty hands-on skills, I said, what I really hope you leave here with is the ability and willingness to apply shared decision making, not just in manual therapy, but everything you do in a therapeutic environment, right? That really is my goal. I just use, touch manual therapy as sort of the way to accomplish that.
Yeah. So let's say for people who might be a little bit newer to these concepts and ideas of shared decision making, how does somebody learn more about this or begin to build skills around this? Because it's something that I don't think is covered very well in most of our, entry-level education programs.
Yeah. Well, okay. So another shameless plug. I have a free 1-hour course on my website available on shared decision making that covers I cover just sort of the tip of the iceberg there. Both if you want the theory, the science, the evolution of shared decision making, but also some more practical ways on how to go about beginning to incorporate shared decision making in your current model. I teach shared decision making from my slow, static MFR style of touch, but I think you can use it with any kind of model. I give the example for physical therapy and exercise, right? Exercise, shared decision making model. There's a podcast that I really appreciate because they're coming from a really strong evidence base in the physical therapy world. But there were two people, the moderator and a guest, who were joking when it comes to patient-centered care. And they joked that it's not like you can ask a patient what they should do for an exercise. And, that kind of got laughs out of both of them. And you can't totally hand it over to them to say, what exercise should I do? Or what manual therapy or massage technique should I do? But I think we can kind of meet in the middle. Like okay, so I'm going to use the example of when I had my rotator cuff repair, 7 or 8 years ago. And, I did the repair, then I went to PT, and my 13-year-old physical therapist, he did a decent job. All right. He seemed like he was about 13, right? But it felt like he was basically pulling the sheet of paper out of the file cabinet, rotator cuff repair, here's what you do, right?
Yeah.
Basically hooking me up with TheraBand, doing the stuff that we do. And all the while I'm grousing because what does this 13-year-old know and all that stuff, and get out of your own way, Walt, etc. But there was a really interesting observation on my part that, okay, I was doing these exercises. And it's like, you know what, this isn't quite hitting that note in my brain of relevance to me. So I never was a good direction follower in school. And, I'm 63 now, I'm still not. Because what I did was when he wasn't looking, I'd start to wander. I'd start to seek and search, and I'm thought like, oh, wait a minute, right there, there's that feeling right there, right?
Yeah.
And I just wish he had taken that time. And it might be a process. It might be part of they don't have enough time, right?
Mm-hmm.
But I also think that we're so locked into here's what we need to do with you that we don't hand over ownership of the responsibility to, at least from a shared perspective, to the patient. Because whether it's that TheraBand exercise or the moves that you and I do with our hands, I think if we can open up that gate to allow them to enter into our yard and share this with us, I think we can have a really interesting relationship. Now, from a massage perspective, and again, I don't want to go too deep into your field or your listeners' field because I'm a PT, not a massage therapist. You have a real problem there with shared decision making because it requires active engagement of the patient, active
Mm-hmm.
engagement of the client, and that sometimes runs counter to maybe one might view as a stereotypical massage setting, where
Yeah.
the patient is allowed to stay quiet, go deep or whatever they want to do. And I was taught that in myofascial release that we need to stay away from words, etc., so they can kind of dive deep into their emotions. And the more I understood about what a bad narrative that the emotions are stored in the fascia story was, and the more I started learning about this stuff, the more I realized that it's important for me to educate, here we go with the air quotes again, educate my patient that this isn't going to resemble what you might expect. I'm very needy. I'm annoying because I'm going to ask you a lot of questions, and I'm going to
Mm-hmm.
keep asking them because I want to make sure that we stay doing something that you feel is relevant and that
Yeah.
you feel is pertinent to your problem, not that I think is important.
Mm-hmm. So that, I'm curious, when you were talking about this, it made me start thinking like, do you think that there's a graduated process? It kind of gets back to that sort of physics metaphor that I was talking about later of like, you have to go through maybe that operator model first to understand how some of the things work in the therapeutic world. And then this is a more sort of advanced level of understanding of becoming an even better clinician, or can you kind of jump to that earlier on without sort of going through that? Do you think that's feasible?
I think you can jump through it. I think for most of our shared professions, everybody already learned the operator model, right?
Yeah.
But I have it's an interesting process in my classes, the voice and swallowing disorders class I teach, because I'm getting speech pathologists who, while they're licensed to touch, the vast majority of them doesn't use any kind of touch-based intervention like we're talking about here. So basically, I'm introducing them from scratch that here's the way you can do it. Not the way it should be done, but here's the way you can do it. And based on the feedback from the people who've been through my program, it can work in that order too. I think that no matter how we learn things, people figure out ways to make it make sense to us, right?
Yeah. Yeah. Well, man, these are just fascinating explorations, and I know we could go down all of these rabbit holes for a couple different hours doing things. So I would like to have you come back and we'll explore some of these things in greater detail again. But until that time, well, how can people find out more about you, your programs, your books, your resources, and things like that? This is opportunity for another shameless plug. Tell us where you are.
Hey,
Yeah.
I am at waltfritz.com. That's probably the fastest and easiest way to find me, waltfritz.com.
Okay.
I've got some newly released online courses, not just in this voice and swallowing disorders, but I released a comprehensive whole body course. An online version, I teach internationally now in terms of that voice and swallowing disorders work. But I really do get a lot of massage therapists coming to those classes, which I love. I love a diverse group. I love conflicting opinion. Fortunately, the fists never fly at seminars, but it's like close sometimes because people are really, you see people struggling with moving away from their beliefs. The book is on there. The book is, like I said, should be out in a couple of weeks, and et cetera, et cetera. Lots of free stuff on the website too, including that shared decision making talk that I gave. And you're welcome to come on and avail yourself of that, even if you don't do anything except that, and see what I have to say.
Yeah.
And Whitney, I'd really enjoy being back again. It was fun to catch up after.
We'll definitely do that. I want to explore this in some more detail, but can you just Also real quickly, maybe talk just a little bit about this work that you do with the swallowing disorders and with the speech therapist in that group, because this is something kind of unusual for a lot of the people that are in, at least my profession in the massage world, of something for them to think about, of like, tell me just a little bit about that there.
Well, without going too far down this rabbit hole, 1980 was about the introduction of manual therapies in the SLP, the ENT world, for muscle tension dysphonia. Muscle tension dysphonia is a voice disorder, often sort of simplified to say hoarseness. And in 1980, a physician wrote about using laryngeal manipulation and laryngeal reposturing. The view that the larynx was too high, they manipulate it to reduce the tone and reposture it. They pulled it down to get a more normal voice. And in their literature, their research, it's been pretty well covered over the past however many years that it's been. But what I really like to watch is evolution of a model, evolution of a narrative, because they went from what I call the what happens in Vegas stays in Vegas perspective, like you and I probably were taught, that the problem's right here. All I need to do is do this, and we drop the muscle tension, or we reduce the trigger, or whatever that is. And you start looking at that research and the writings from the 90s, et cetera, and it's all about what happens in Vegas stays in Vegas. And then there's papers that sort of in the 2000s talked about, while we think the problem is here, we understand that it's a cascade of events up and down from the brain, until in 2017, Nelson Roy, a PhD from the University of Utah, did a study where they basically handed a woman with muscle tension dysphonia a script. They slid her in an MRI, and they had her read the script, and they watched her brain. They saw the atypical patterning of her brain when she spoke, and then they pulled her out of the machine. They did the equivalent of an hour's worth of laryngeal manipulation, and then tapering to see if she could hold those gains. And then they slid her back in the machine. She read the same script again, and what they saw was a different acting brain. That in that course of one session, that her brain was completely functioning in a different way. The paper doesn't prove that it's not in the tissues, it's in the brain. But what it shows is that interplay between the human, the nervous system. And it's not just about what happens in Vegas. And I think if educators could move away from that sense that it's all right here, there's a paper, you probably read this one, by Kolb, I think it's 2019, Manual Therapy Education. It's time to move on. And to me, that's what people in our field should really be reading and say, can we start explaining this work from multifactorial perspectives?
Yeah.
I kind of diverged from your original question. Sorry about that.
That's all right. I love those divergent pathways that we head down. So, and like I said, I know you and I can talk about this for hours on end here. And so I want to thank you again so much for coming to be a part of our discussion today. This was absolutely delightful. And I certainly want to have you come back and do this again with us. So I hope you'll do that.
I will. I'm honored to be here. So thanks. Good to catch up again.
Indeed, indeed. Well, thank you for being with us here on The Thinking Practitioner. And do keep in mind, Books of Discovery has been a part of massage therapy education for over 20 years. Thousands of schools around the world teach with their textbooks, e-textbooks, and digital resources. And Books of Discovery likes to say learning adventures start here. And they see that same spirit here on the Thinking Practitioner podcast and are proud to sponsor our work, knowing we share the mission to bring the massage and bodywork community closer together. So thank you to all of our sponsors. You can stop by our sites for show notes, transcripts, videos, audio feeds. You can find that over on my site at academyofclinicalmassage.com. And over on Till's site. Till is off in Thailand right now in Asia. So I'm going to be doing a couple episodes without him. So he's doing some training over there, and he'll be back shortly. You can find that over on his site at advanced-trainings.com. If you've got questions or things you'd like to hear from us or hear us talk about some more, please do email us at info@thethinkingpractitioner.com, or you can look for us on social media. You can find Till over his name, Till Luca, and also for me in social media over on my name, Whitney Lowe, as well. And lastly, if you can, take a moment to rate us on Apple Podcasts, as it does help other people find the show. And you can hear us, of course, on Spotify, Stitcher, Google Podcasts, or wherever else you happen to listen. Make sure to subscribe to us on your favorite podcast app, share the word, and do tell a friend. Thank you again, my good friend Walt. Wonderful talking with you here. And thanks everybody else for hanging out with us today. We'll see you on the next episode.